Welcome all to all the attendees from where they are listening from. Welcome to the first City of Hope Global Oncology Forum. I am Javier Gordon Ogembo, the Director of City of Hope Global Oncology Initiative. Briefly, I would like to tell you about City of Hope. City of Hope was founded in 1913 as a tuberculosis sanatorium. And since then, it has transformed into an independent biomedical research and treatment center for cancer, diabetes, and other life-threatening diseases. We are home to scientific invention that led to the development of human synthetic insulin, monoclonal antibodies, numerous breakthrough cancer drugs. Our history of leading-edge research, groundbreaking treatment initiatives, partnerships, and collaboration culminates in providing compassionate patient care through 30 locations, making us one of the most highly regarded cancer centers. Today, I'm proud to announce the launch of City of Hope Global Oncology Initiative, which stems from our understanding that it will take more than a village to address the increasing burden of global health. We aim to organize City of Hope's researchers, clinicians, and educators, and expand local and global partnership to tackle current and impending challenges in cancer and global health. As part of this initiative, Global Oncology Forum will cover a multitude of topics and help disseminate scientific findings to a broader audience, and serve as a platform to engage our communities, open barriers, and challenge the boundaries. Today, our Global Oncology Forum will focus on COVID-19, where we are now, and what next. We are delighted to have 5 experts on this topic who have graciously agreed to be part of our panel. I'm thrilled to say that we have over 600 attendees across the globe joining us from all over the world. A note to our audience, please submit questions to ask our panelists through the chat box, and recording of this event will also be available. Without any further delay, it is my great pleasure to introduce to you our moderator of this inaugural event, Dr. Stephen Rosen, a world-renowned medical oncologist and hematologist, provost, and chief scientific officer of the City of Hope, Iriel and Manela Cancer Center, director, distinguished chair, and Morgan and Helen Chu, director, chair of the Beckman Research Institute, who is the catalyst behind this global initiative. Dr. Rosen, welcome.
Thank you, Dr. Ogembo, and welcome to all of you from around the globe. We're very proud of this initiative. It's very fitting after this surreal year that we focus on COVID-19. Just weeks ago, we thought that this was behind us, and now I think there are more questions and somewhat confusing issues than in the past. We're fortunate that we have 5 very distinguished faculty who are leaders in the field and are going to provide the up-to-date information. There'll be brief presentations followed by a question and answer session. This is actually our inaugural event, and we hope to learn a great deal as a result of this program. The presentations will focus on the nature of the virus, epidemiology, vaccination, therapy for infection, and emerging variants and testing. The first presentation will be by Dr. John Zaya. He's the Aaron and Edith Miller Chair for Gene Therapy, professor and director of the Center for Gene Therapy, and an authority on viral diseases. Dr. Zaya?
Thank you, Dr. Rosen, and hello to all of those around the world who are joining this seminar. My job is to talk about coronavirus in the big picture and to talk about why you get sick with coronavirus, what is this issue about increased infectiousness of some strains, and basically tee up the panelists for doing a deep dive on exactly the specifics of the problem. So let's begin. A virus, of course, is a small particle. It's an encapsulation of some genetic information. And the sole goal of the virus is to make new copies of itself. It has to find a cell, make the copies, and then spread to other areas. If it can't do that, it will die out. Coronavirus, and it's called coronavirus, as we all know, just because of what it looks like, the corona of the sun. It has little budding areas around the surface of a round sphere. And those budding surfaces are part of the protein that holds the virus together. It has really 4 major proteins. The spike protein, which is the protein that's looking for other cells to bind to. And then it has a membrane, it has an envelope, and it has the internal protein that protects the RNA. The RNA, of course, encodes many proteins, about 16 proteins, in addition to those 4 structural proteins. And those are the proteins that help the virus replicate. And they're involved in making people sick. And there's many kinds of coronaviruses, of course, across all species, especially in mammals, but not necessarily only in mammals. But the coronaviruses we're worried about are the 7 that infect humans. 4 of them cause the common cold, and about 15% of all colds are caused by coronavirus. But the 3 new ones that are a problem. In 2002, we heard about severe acute respiratory syndrome virus called SARS. And later on, another decade later, we heard about a disease in the Middle East that actually came from camels called Middle East respiratory syndrome virus. And that was a particularly deadly one because about 20% of people who actually caught that virus died. But it died out, or at least has not been a major problem because its infectiveness was not sufficient, that it couldn't spread as well. So how does the virus spread? It really has to find that receptor on your cell, and there are receptors called ACE2 proteins. And those ACE2s are normal proteins that help our bodies work. You know, they control important things like blood pressure in the body. So many cells have these, and the virus can latch onto those through the spike, that spike protein that's on its surface. And the issue is, will that spike stay the same in every virus, or can it get better at infection or binding? And that's the problem. The virus can change. So why does the virus change? Well, it's replicating continuously, and there's millions and millions of viruses that are being made each day in an infected person. And the RNA copying is not what they call high fidelity. It makes mistakes. And some of these mistakes lead to better proteins. And those better spike proteins can bind in a better way and make the virus more infectious. So these are the so-called variants. And some variants just are more infectious than others. And we're going to hear about those in just a minute. But for example, the one that we currently have is the Delta variant. And it has an ability to be infectious that's about 3 times more than the original virus. And that is the reason why the virus is spreading. And then as it spreads, it becomes dominant in the population. So in the United States right now, 83% of all cases are due to Delta. Now that wouldn't be a problem if it doesn't make people sicker. But certain variants do increase the hospitalization rate, the severity of disease, so there's more ICU admissions, and then there's more deaths. And that's one of the problems. So how do we prevent that? And that's the goal of this panel, to describe that. I think I'll stop there and allow Dr. Rosen to introduce our next panelist. Thank you.
Thank you, Dr. Zaya. Our next speaker, Dr. Randy Taplitz, will address the epidemiology. Dr. Taplitz is professor and chair of the Department of Medicine and a renowned figure in infectious disease. Dr. Taplitz?
So as we know, in December of 2019, these cases of this new coronavirus were described in Wuhan with cases of pneumonia. And within a few weeks, the virus was identified and the first PCR tests established. But by March 2020, with more than 118,000 cases in 114 countries, the World Health Organization declared that this was a pandemic. So I want to just talk about a couple of important concepts in understanding the spread of COVID from an epidemiologic perspective. Although it's a dynamic measurement, the R0, which is, I'm sure, something that people have heard about and read about in the newspaper, is the basic reproductive number of the virus. And it's really a tool, an epidemiologic tool that helps us predict the expected number of cases from exposure to a single case, assuming that all given individuals in the population are susceptible. So the R0 of a virus that is a very easily spread virus, such as measles, is in the range of 12 to 18, which basically means that for every person who has measles, one could expect 12 to 18 secondary cases. This is a very, very high R0. The R0 of seasonal influenza, which is another, obviously, the important respiratory virus that we think about every year, is in the range of 0.9 to 2. Based on the data so far, the R0 for the original COVID-19 strain is in the range of 1.4 to 3.9. And for Delta, it's likely in the range of 5 to 8 or even higher. This is a critical feature in the epidemiologic spread of COVID. For instance, one of the viruses that Dr. Zaya mentioned, MERS coronavirus, is thought to have an R0 of less than 1. That basically means that each infected individual infects less than one person, which is why MERS is unlikely to ever cause a super large outbreak or be a pandemic. But it is also the reason why SARS-CoV-2, and in particular the Delta viruses, are so concerning. So in other really important epidemiologic considerations include the concepts of incubation period, pre-symptomatic phase, and asymptomatic infection. Because the incubation period of SARS-CoV-2 is 2 to 14 days, the potential for contagiousness exists during this time, which is why quarantine after exposure for a more prolonged period of time than what we are used to with other viruses has been indicated. Importantly, the pre-symptomatic phase is when an individual is infected and may be shedding virus, but hasn't yet developed symptoms. Importantly, viral loads with COVID, unlike a virus like SARS, for instance, tend to be very, very high in the upper respiratory tract in this pre-symptomatic phase, which means that there's the potential for transmission even before symptoms appear. In fact, it's actually been estimated that 44% of transmission events actually occur during the pre-symptomatic phase of the index case. And this is very important in household clustering and et cetera. In a number of studies, high nasopharyngeal viral loads before or around the onset of symptoms have been shown to contribute significantly to secondary transmission of COVID. In one study, higher respiratory tract levels of virus, of RNA, taken at a median of a couple of days after symptom onset were independently associated with a higher secondary attack rate. I think, and as Dr. Zaya said, and you'll hear more about, importantly for Delta compared to the original virus, the viral load has been estimated to be in the range of 1,000 times higher and is likely higher earlier in the pre-symptomatic phase than for the parent virus. So all of these things, this combination of the high R0, the high viral load, and other features which I will not talk about, such as potential for improved immune evasion of Delta, means that the Delta variant reproduces readily and is very highly transmissible. And some estimates suggest that almost 200% more transmissible. So what does that mean? So prior to Delta, data suggested that vaccine breakthrough infections, e.g., diagnosis of COVID after being fully vaccinated, the viral load in the nasopharynx was reduced and suggested a lower infectiousness and lower likelihood of secondary spread than in unvaccinated individuals. Since the advent of Delta, we are clearly seeing a higher rate of vaccine breakthrough. I think that our vaccine panelists will talk more about this. One of the things that's really important, though, to remember is that even though in these vaccine breakthrough cases, only a small proportion of these occur in fully immunized individuals. And when they do occur, they tend to be less ill, with relatively few requiring hospitalization. I think one of the things, and I want to just finally speak about sort of the new CDC mask guidance, because I think that's really important, and why that came about. There's some early data from a recent study of breakthrough infections in healthcare workers. There's one from India and one from Israel, suggesting that vaccine breakthrough with Delta may be associated with higher respiratory viral loads compared to non-Delta infections, as well as better transmission between healthcare workers. So there's a lot of reasons because why we're worried about this Delta variant, the high viral load, the increased transmissibility of Delta, as well as vaccine breakthroughs, which may be a little bit less important, but really more important, the less than ideal rates of vaccination in our country and others. They're really the main reasons the CDC yesterday changed its mask policy in vaccinated individuals, as well as unvaccinated individuals in the setting of this surge of Delta virus. So I think I will end by just saying, I wanted to say a word about the modes of transmission, because obviously that's something that evolved earlier on in the pandemic. when we were discussing whether this was a droplet spread or an airborne spread. And I think really what we understand now is that the principal mode by which people are infected with this virus is through exposure to respiratory fluids carrying the infectious virus. And this can occur by inhalation of very fine respiratory droplets and some aerosols, or deposition of respiratory droplets on exposed mucous membranes, or by touching mucous membranes with hands that have the virus. And really what we know is that, what's really important is that risk factors for spread of the virus in terms of the mode of transmission, we stay away from enclosed spaces with inadequate ventilation. We worry about prolonged exposure, particularly in those kinds of settings. And we really mitigate risk in a variety of different ways, but most importantly, we mitigate risk by vaccination. And I'm gonna leave it to our next speaker to talk more about that. But again, as the CDC has now recommended, really recommending now for even fully vaccinated people to wear a mask in public indoor settings in areas of substantial or high transmission. And that can be reviewed if you go on the website, the CDC website, you can find what qualifies as substantial or high transmission. And then further, and very important to our population here at City of Hope and elsewhere, fully vaccinated people might choose to wear a mask regardless of the level of transmission, particularly if they're immunocompromised or at increased risk of severe disease in other ways, or live with immunocompromised individuals. And I think I will stop there, and we'll move to the next speaker, and then we'll take questions. Thank you.
Thank you, Dr. Taplitz. Our next speaker is Dr. Don Diamond, who's an acclaimed virologist and immunologist who actually has constructed a next generation vaccine. And Don is the professor of the Department of Hematology and Hematopoietic Cell Transplantation. Dr. Diamond.
Thank you, Dr. Rosen. It's a pleasure to be here. And I'd like to add to the very excellent descriptions and discussion that the physicians started. And so I also have noticed that there are a number of questions that from the audience, and I would be happy when we get to that point to begin to answer some of these questions, because they are at the top of mind, especially for people who are immunocompromised, about how well are they protected from the acquiring the infection based upon the vaccines that the FDA has made them, it's called EUA, or Emergency Use Authorization, and they are allowed to be distributed and used by the public. But I want to step back and talk a little bit about the vaccines. Of course, I would love to talk about our vaccine as well, but I think I'll first talk about the fact that what we call efficacy, or how well they work, of the three major vaccines is remarkable. And I want to leave sort of the impression to the audience that this has been unprecedented in terms of how quickly we got to developing an effective vaccine. But more importantly, because I think that's what's most important to people who are wondering whether they should be vaccinated, is that these vaccines, the three of them that the FDA has granted emergency use authorization, or EUA, are remarkably safe. Now, of course, you have heard about various incidents of what we call adverse events, or situations where individuals may have a reaction to the vaccine. Social media, those who have an agenda that's beyond public health, have made a lot of discussion and have broadcast that to the public. But if we look at two things that we need to remind ourselves, the first is the hundreds of millions, it's actually over 1 billion doses have been given worldwide. The number of adverse events that are of consequence are a few hundred. Now you may say, well, a few hundred adverse events, I don't want that to be me. What you have to balance is the consequence of not being vaccinated. Around the world, we don't even know how many people have perished because of this disease. It's in the millions. We have no idea how many people have perished in India. We have no idea how many people have perished in Brazil. And we probably don't even know how many people have perished in the United States, either directly or indirectly because of COVID. So I wanted to at least set the stage that these vaccines that have been granted EUA status are remarkable. They're remarkably safe, and let's address what people are concerned with as well. They are remarkably effective. There are few examples in medicine of a vaccine that is as effective as the 2 mRNA-based vaccines. So people commonly call them the Moderna or the Pfizer. Both of these vaccines at the onset and for, in most cases, 6 months later after you have gotten both doses are over 90% effective, which means that in acquiring the infection, they prevent at least 90 and in some cases 95% of infections. But the most important thing about these vaccines is that they're essentially 100% protective against hospitalizations or death. And let's face it, that's what we want to prevent, those two terrible events that have afflicted our country as well as worldwide. Unfortunately, the situation has changed from 12 months ago. And Dr. Fauci, who is our leader in terms of research and our spokesperson for public health pandemics such as this one, has stated that it's not that the science is wrong, it's that the virus has changed. And Delta, which Dr. Taplitz has begun to discuss, is an example of what happens when the preponderance of people worldwide have yet to be vaccinated. While this virus is not nearly as changeable as a virus such as HIV, if there's enough of it, there will be changes. And as time goes on, some of those changes, as Dr. Zaya mentioned, may just by chance become more infectious, more transmissible, more virulent. And that's essentially what's happened with Delta. The vaccines that we know are effective against some of the prior variants and the original virus, unfortunately, are not as effective against Delta. They are effective against hospitalization and death, but they aren't quite as effective against acquiring the virus. And now we know from studies in China, as well as the rest of the world, that there is greater amounts of virus in essence in your nose. And of course, if you sneeze or you breathe through your nose, virus can escape and infect another person who is maskless or is around you. I also just briefly want to mention the situation with the immunocompromised. At City of Hope, we have quite a number of patients who are immunocompromised. And it's understandable that many of them are worried whether they are protected against acquiring the virus because they've been vaccinated. Truth be told, we don't have all the answers. We know that there are certain disease states in which the vaccines are more or less effective. It's not a generalization that the vaccines are not effective for all cancer patients, but there are certain modalities in which the vaccines are not as effective. I urge you to consult with your physician and to discuss the options and what can be done. But I think, as now has been proclaimed by the CDC, it's better to be safe than sorry. Masks for indoors are required, and if one is really concerned, which I'm sure all of you are, then you must practice social distancing. The further you are away from an individual who by mistake or some other reason has acquired the infection, the better off you are. So I probably have exceeded my time, and I'm happy to answer specific questions when that comes up regarding the various new forms of the virus. But I did want to at least reassure people that the vaccines that the government is acknowledging are safe and effective are actually safe and effective. Thank you.
Thank you, Dr. Diamond. Our next presentation will be by Dr. Sanjeet Dodwell, who is Professor and Chief Division of Infectious Disease. He'll be addressing the treatment of infection with COVID-19. He's a highly regarded clinical investigator who's an expert on the treatment of all infections. Dr. Dodwell.
Thank you, Steve. Good morning and good evening to the audience who is here from all parts of the world. Thank you for attending. And I would like to start by just stating this, that the treatment actually is not the best way to deal with COVID. It is prevention. And as Dr. Diamond mentioned, vaccination is the key. I just wanted to highlight that part. And the unfortunate reality is that we do not have great effective medications in terms of antiviral medications. We do have an FDA-approved drug known as remdesivir, which is approved for moderate to severe disease. However, it did not lead to any survival benefit when it was looked in phase 3 trials, which were randomized open label trials between patients who had received placebo or this antiviral drug for 5 days or 10 days. So again, main thing is get vaccinated. And again, because where I work at, it's mostly immunocompromised patients, and we make it a big point that the family members, caregivers get vaccinated, because at least they can sort of cut that line of sort of dissemination of virus to their patient, to their families or dear ones. So there is guidance across various health agencies such as NIH, IDSA, which is Infectious Diseases Society of America, and WHO. And there are some differences between each of those societies, how they look at the evidence. And the COVID-19 ranges from asymptomatic disease or infection to severe disease, and it's mild, moderate, or severe, and that depends upon whether they're requiring oxygen or they're not requiring oxygen or they're in a hospital. So in mild to moderate disease patients, these are patients who are non-hospitalized. The goal is to reduce viral replication with the intent to reduce the risk of progression to severe disease and hospitalization. And for that, we have emergency use authorization for certain monoclonal antibodies. And these are 2 right now, which are allowed by FDA. There used to be 3, but now it is 2. One is casirivimab and remdesivimab, and the other one is newly approved sotrovimab under EUA. They are not fully FDA approved. And there are certain criteria where you can use those monoclonal antibodies. Again, these are for those persons who are at high risk for progression, meaning elderly patients, obesity, diabetes, immunocompromised states, and there's a whole list. And it has to be given within a certain period of time to be effective. Now, moderate disease patients are those who have evidence of pneumonia, but they either do not require admission, but if they do require admission, they can be treated with remdesivir. If they are not, then they can get monoclonal antibody in consultation with their physician. Severe disease is where the patient requires oxygen, whether it is a low level of oxygen or high flow oxygen, or they're on the ventilator. Again, NIH guidance indicates you could use remdesivir along with Decadron, which is dexamethasone steroid, and that is based upon a clinical trial which was run in the UK, where it showed actually there was mortality benefit. So in terms of antivirals, we only have remdesivir at this point. There are clinical trials ongoing with various different agents, and the other one is Decadron for severe disease. And one of the most important thing is if, especially after this happened quite rampantly in India, was people were getting mild disease and they were really ramping up on Decadron. And it is unclear whether that led to the big black fungus outbreak which they had, or there was an element of unidentified diabetes on top of those steroids, which led to that. So certainly you don't want to misuse steroid doses down there. So that is basically what it is in terms of antivirals. So most of the management for COVID-19, when it gets to a severe stage, is supportive management. So this includes a lot of things: anticoagulation, agents which reduce inflammation. In fact, I did not mention there are certain drugs which act by reducing certain inflammatory markers, like these are IL-6 inhibitors, and tocilizumab is now recommended in those patients who are going to ICU, meaning within 24 hours, if you give, there seems to be benefit from some studies. And when it's time for questions, I'll be happy to take some questions. Thank you.
Thank you, Dr. Dodwell. Our final presentation will be by Dr. David Ingenthaler. David is the co-director of our affiliate TGen in Arizona's Pathogen and Microbiome Division, and he's an international thought leader in the molecular analysis of pathogens. Dr. Ingenthaler.
Thank you, Dr. Rosen. And it's a pleasure to be on this panel with such esteemed investigators and clinicians. As you all can understand, I represent the genomics side of this discussion. And really more so than ever before, genomics has played a critical role in understanding and responding to infectious diseases. And we think that hopefully we can carry that forward beyond this pandemic. But it has been instrumental in almost every part of the response. The very first genome sequences were produced and shared by Chinese scientists back in the early part of January 2020. That data was used by labs all over the world to make highly accurate diagnostic tests. That data was also used to create the mRNA vaccines and other early vaccines. Researchers, including some at City of Hope and at TGen in Arizona, have used genomic data to understand the genetic factors associated with host cell binding and entry, like we were hearing earlier. And early genomic sequences provided the baseline data to start tracking this virus as it moved around the globe, mutating and changing along the way. Genomic sequencing is really gives us real intel on this virus. It's the only way that we can truly understand this virus as it continues to become now another human adapted coronavirus. We've been witnessing in real time one of the important lessons that we hopefully all learned in high school biology: evolution. And one of the key ideas of biological evolution is the concept of survival of the fittest. This virus has really been evolving ever since it broke out of Wuhan, China. The variants that we saw first emerging in Italy and other parts of Europe quickly spread across Europe and into the Americas, and that became our pandemic last year, fairly early last year. It had picked up a mutation in the spike protein that made the virus more transmissible. We called it at the time 614G. That was the name of the mutation, but that really was a new variant, and it became the face of the pandemic for much of the world. This gave the virus a distinct advantage in helping it continue to spread globally very quickly. So it was a bit different than what originally came out of Wuhan. And then there was the strain originally known as the UK variant, subsequently called B117, and now Alpha, as we pick on the Greeks and use their lettering system to call these viruses now. It emerged in October-ish of 2020. This variant proved to be even more transmissible than 614G, and essentially it had additional spike gene mutations. So it made essentially a supercharged virus even more supercharged. And about the same time, this was happening in California as well. That new California variant was identified. There were two of them. These were known as B1427 and B1429. We now call this Epsilon. It too had additional spike gene mutations, which caused faster spread, as well as some evasion of antibody treatment. So now a concern that it's evolving to evade our own immune response. Then there were the South African and Brazilian variants, we call now Beta and Gamma. Again, faster spread and some antibody evasion. So there's this, you can see this push for this virus to become more rapidly spread between people. That is what is making it the most fit. And now there's the Delta, originating out of India, as we know, during their recent massive surge, has proven to be really hands down right now the winner of this survival of the fittest race. It spread 60% faster than the previous leaders in this race and has become pretty much dominant everywhere that it shows up. As we heard, Delta makes up greater than 80% of the cases in the US, as well as certainly in California. In Arizona, it's probably right about that, 75 to 80%. And those percentages will continue to increase based off of what we understand. This variant, as we've heard, infects cells more easily, leading to faster replication, higher viral loads, more transmission. However, it doesn't seem to increase severity, which is, if good news is there, that's the good news. If anything, we're seeing less severe outcomes overall, partially because it transmits so quickly in younger populations, which have less risk for serious disease, partially because we've taken our highest risk populations for the most part off the table with our high immunization rates in the elderly, really preventing the worst outcomes in most cases. But perhaps this ultimate winner of the survival of this might be the ultimate winner of the survival of the fittest race. That would be good because the vaccines work great against this and the other known variants. However, we're still at tremendous risk for new unnamed variants to show up because many places around the world don't have the vaccination rates we have, and ours aren't even perfect, but we're seeing less than 10%, less than 5% in many countries and in parts of the world. Delta will spread like wildfire in these places, and that means new mutations may occur because of all the transmission, resulting in a new variant that might be more severe or more resistant to our vaccines. So hopefully it won't. Hopefully we can get more vaccines out to the far reaches of our planet to help prevent that and maybe prevent us from having, what we could call an Omega variant to end this pandemic. Steve, I'll turn it back over to you.
Thank you, Dr. Egenthaler. So now we're going to go to questions and answers, and there's been a robust response from our audience, starting Dr. Zaya with why is this coronavirus different than the others that have been with us for decades, and why is there a variation in how sick individuals become? You're on mute, John.
I think we can summarize by saying we don't really know for sure. With any cold, some people in the family get sicker than others. Why does that happen? We don't know. There are pathogen factors, there's host factors, and why this particular virus is producing more disease is probably related more to its infectiousness than to its virulence. In other words, if you have, like we say, 200, 300 times more cases or more spread, you're going to see, and the complication rate is some percentage, you're going to see more complications.
Thank you. Randy, can vaccinated individuals spread the virus?
Yes, as we are finding, and it's interesting, of course, because that discussion has changed a little bit with Delta. What I would say is that is still data that needs to be gathered about that, but vaccinated individuals can certainly spread the virus. That rate of secondary spread, though, is lower than in unvaccinated individuals, even with Delta.
Randy, if you go to China or Japan, in all the hospitals for years, individuals have been wearing masks pre-COVID-19. Do you see that as the future in American medicine, that we'll be wearing masks as we work in the hospital?
So it's an excellent question. We've been actually discussing that in our kind of weekly COVID meetings. You know, I'm not sure I necessarily see that in, you know, community hospitals or all around, but it wouldn't surprise me if in hospitals such as City of Hope, where we take care of a lot of immunocompromised individuals, that would be a much more standard approach. And I just, you know, I think one of the things about this pandemic is we will never go back to where we were before. I mean, meaning we will always, you know, I think people will have their masks at home. People will have them in their desk drawers, right? Because, you know, the potential for this has been unleashed, and we're very well aware of it.
We haven't heard much about influenza. Has that disappeared because we're all wearing masks?
So it's actually really interesting. We saw a tremendous decrease, almost very, very little influenza. Sort of after the initial part of the pandemic, we did see an increase in other respiratory viral infections, but not so much influenza.
Dr. Diamond, tell us about the booster. Is that going to be the next step? And I've heard some anecdotes, at least in my patients who are immunocompromised, that after not responding to initial vaccinations, they did respond to a booster. Also, can you comment about what's unique about the construct you developed, which may be the next generation?
Thank you, Dr. Rosen. So I think I'm on safe grounds by saying that boosters are inevitable. The question is only when and who will get them first. We know this from Dr. Fauci. Of course, the companies are interested in selling boosters, but more importantly, our government officials recognize that the vaccines, while they have been almost perfect at the onset, as time goes on, and this is true for most vaccines of this type, that their effectiveness begins to decrease. On top of that, we have this very concerning Delta variant, which may not be the last variant that will hit us. And we know from data from the companies that they have shared with the FDA, they are not as effective, even in healthy people, against the newer variants such as Beta and now Delta. The traditional vaccines, we can call them traditional now, even though it's pretty early in the vaccine world. They've only been available to the public since early or late 2020. They all have a similar mode of action, we call it. That is, they work the same way. All of the EUA vaccines work the same way. The Johnson & Johnson uses what we call a different platform, but the fact is they're all based on the same principle. The vaccine that my colleagues and I have developed at City of Hope has a slightly different principle. We are thinking actually for the long term, because we are banking on the fact that both antibodies and what we call T cells are important. And in fact, in studies carried out in humans, as well as what we call preclinical studies, in fact, T cells are very important. In the latter stages of the vaccination, it may be that what is most important are the T cells. I'm happy to report that our vaccine is quite potent at stimulating T cells. The other vaccines also stimulate T cells, and it may be that the T cells are what keeps us healthy as the antibody response begins to draw down. In terms of the immunocompromised, I am a strong believer that a booster shot, and especially one that comes from a different platform than the original vaccine that an individual might have gotten, would be very effective. And as Dr. Rosen said, there is data already that getting a booster, if you have any prior response to vaccination, will increase your responsiveness. And there is other published data that if you use a second platform, a different one than the first platform, that there are greater benefits in terms of increased responsiveness. So I think we really have a lot to look forward to. And we at City of Hope are engaged in discovering our platform and how it will work in the immunocompromised, because we recently have been given permission by the FDA to begin to investigate our vaccine in our patient population. It's a clinical trial. I have to emphasize that. That is, we don't have any approval from any agency to give it broadly to the public. But what we are going to be investigating in our patient population is how our vaccine operates and how well it does. And we have future plans, but we have yet to approach the FDA, of including a booster as a way to increase the responsiveness of patients who might not have responded as well to the current EUA vaccines. Thank you.
Dr. Dahman, I just want to make it clear that when you say a different platform, you're saying essentially if you got Moderna, you can get Pfizer or Johnson & Johnson or your vaccine.
That's correct. I was trying to avoid the technical terms, but maybe I overdid it. But yes, it's been shown and been published in the best places that one can start with Moderna, switch to Pfizer, or start with Pfizer and go to Johnson & Johnson, or start with AstraZeneca. And in fact, in Britain, they are recommending that one only get one AstraZeneca and then get a booster or the second shot with Pfizer. So there's a lot of data out there saying that these vaccines can be mixed and matched without severe adverse events. There is reports, and there was a publication in Lancet, that if you have, if you take a vaccine from a different variety, you may incur, at least short term, a little more discomfort. Not excessive, but it may be a bit more discomfort. But the benefit is that you may have more protection. We don't know.
And the booster should be how many months after the original vaccination?
So what's been discovered through trial and error, that the longer you wait after the first vaccination to receive the second one, in general, you get a better immunity to the virus. And so what's happening now is in Britain, they're suggesting 12 weeks. So you get, they were a big receiver of the AstraZeneca vaccine, which is not as effective as the Moderna and Pfizer. And so they recommended the second shot be one of those, and they're waiting 12 weeks. And they're waiting 12 weeks because they don't have enough vaccine. But the fact is that what they have found is that people respond better if you wait a bit longer. And the booster, and so in what's being suggested in Israel, although it's not policy yet, but the suggestion is that you wait at least 6 months from the completion of your first regimen. So either it be 2 vaccines or 1, that you wait at least 6 months to receive a booster. And that's the plan in Israel. And I'm guessing in the United States, it'll be some variation of that plan.
Thanks. Dr. Dodwell, what's your thoughts on the use of antibodies in a prophylactic manner, in particular high-risk individuals who may be immunocompromised?
Yeah, I'm saying it's a attractive approach when we know that certain high-risk patients may not respond to vaccines. You know, we American Society of Hematology and American Society of Transplantation and Cellular Therapy have the guidance on vaccinating those patients, and there are some groups where likelihood of inducing a response is very low. So it makes perfect sense. I think this was one of the ideas we had made, sort of presented to the companies who make these monoclonal antibodies, and there was interest, and then COVID went down significantly. Now it is up on the rise. I know for a fact that Regeneron has done studies in the setting of post-exposure antibody, and it seems like it worked very nicely in nursing home setting. So certainly a thing which should be investigated further. But again, it all depends what's the prevalence of disease in the community. Where is it safe enough to give periodic sort of monoclonal antibodies, and how frequently do you give it? That's something which should be studied.
Thank you. Dr. Egenthaler, I promised a friend I would ask. Her son was exposed in hockey practice to someone who was COVID-19 positive. How often should the child now be tested, and for how long?
Yeah, it's not totally known. It doesn't make sense to start testing right away. Maybe wait until day 3, and if there's an opportunity for regular testing, I would recommend being able to do that. That might even be daily or every couple of days, because by and large, most individuals will be able to, especially if they're asymptomatic, be able to clear the virus pretty quickly. And once you clear the virus, you're negative on a test after you've been positive. CDC says 2 tests 24 hours apart. Then you're essentially cleared to go. And that in some cases can happen real quickly. In other cases, that could extend out, and you could have prolonged virus in your system for, it could be a couple weeks or more. So it really does depend on the state of the individuals. If they're not symptomatic or only mildly symptomatic and those symptoms go away, they might be able to clear the virus pretty quickly. And you can only really determine that by testing.
Thank you. A colleague just went to Italy and Germany, and apparently they have rapid antigen testing that you can get the results in 15 minutes before you go in a store. Could you describe what that test is and how accurate it is?
Yeah, actually, rapid antigen tests have become really prevalent, especially in our healthcare system. Pediatrician's office, my son just had one of these done. It's essentially like the pregnancy test, and it can give you a really quick assessment whether or not you have an active viral infection, because you're detecting the antigen, the protein, and typically it's the spike protein in an individual. They're not as accurate as the PCR test, but they're much cheaper. They're much faster. They'll likely miss some people that have very low level of virus, and those are at lower risk anyways for the most part. So it's not a perfect test, but they are becoming widely available and used to be able to rapidly screen individuals to see if they have active viral infection.
One controversial issue is where the virus originated. Was it in the marketplace, or was it in the Wuhan laboratory? Does it make a difference? Will we ever know?
Well, from my perspective, I used to be in the epidemiology world and the biodefense world. This is a really important issue when we think about if the possibility was a lab leak. We didn't have enough biosafety precautions in place in that particular lab. Labs around the world have been dealing with this issue for decades. We have had lab leaks in the past, and we try to figure out, how does that happen? How do we prevent it? What type of experiments are happening? And maybe we need to increase safeguards. To understand that question, I don't know that we're going to solve it here. There's a lot of circumstantial evidence really on both sides. And if you were trying to potentially indict the lab, yeah, you could probably get an indictment with the amount of circumstantial evidence. Right now, there's no way to convict or to convict the natural side as well. There's previous historical evidence to say that it could actually come out of maybe a transfer to another animal and then into humans. That is still very likely possibility here. So it's, those are probably fairly even. I don't think we're going to solve it.
Dr. Taplitz, recently the VA mandated vaccination for all employees. A number of other medical centers and even corporations are now mandating vaccination for all employees. Do you think that's going to be the future within healthcare?
Yeah, so I think that the country is moving in that direction. I can tell you that at City of Hope that that discussion is happening tomorrow and early next week, with probably a response by the end of next week. But I do think that every day you read about more healthcare systems, California and New York public workers, I think that we're moving in that direction. Yes, there will, I think that, exemptions will exist for religious and medical reasons. But I think we're headed towards, in certain settings, mandatory vaccination.
So I want to thank all of you. Gordon is going to end the discussion. It's 10:30, but before we go on our way, one of the most controversial issues is whether children should be vaccinated, young children, since the risk of dying from COVID is so low compared to all other causes of death, and we don't know the long-term consequences. Does anybody want to make a statement about children being vaccinated at this juncture?
I would be happy to. So the fact is that with the onset of Delta, there is an alarmingly increase of younger people landing up in the hospital setting. Now, one can argue why that's happening, and we've heard various discussions about that. The older population has been vaccinated, and therefore the virus only has the younger population. But I don't think that's really the answer. I think the answer is that this particular variant, because it is more infectious and more transmissible, is in fact impacting younger people to a greater extent. The answer is that individuals in which the FDA has already stated are safe to be vaccinated should be vaccinated. So right now, from 12 onward, it is safe to vaccinate. And Pfizer, for sure, has emerging data, which they're presenting to the FDA, to go all the way down to 5. It is my personal view that based upon the safety of this vaccine or the EUA vaccines in the adult population, that the risk reward of having even a child vaccinated is definitely worth it, as opposed to acquiring an infection which may have consequences that go on for a very longer period than people actually realize. And so the answer to me is you need to vaccinate for all children in which the FDA has signaled that it is safe to vaccinate.
I want to thank all of you for sharing your knowledge, and I'll turn it back to Dr. Ogembo.
I think somebody has blocked my video, one of the co-hosts, but that's no problem. Thank you very much, Dr. Rosen, and to all our esteemed panelists for a very informative discussion. I want to thank all the audience who engaged in this conversation and submitted questions. I'm also excited to announce our next event, the Global Oncology Forum on Precision Medicine, which will take place November 8th. So if you put in your calendar, November 8th, 4 to 5, I invite you all to who joined today and invite others, and we will be sending out a notification. Thank you very much.